My name is Stan Hunter. Teresa Wilson and I are colleagues, and we will be moderating today's session. Again, if you could go on mute unless you're speaking, and go off of video unless you're speaking, that would be great. This is the 13th session of the Healthcare Acquired Infections Organization series, and regarding the COVID-19 pandemic. So welcome everybody. Next slide, please. Great. HAIO was started in 2013 and stands for Healthcare Acquired Infection Organization. It's a collaborative community of healthcare facilities leaders, healthcare executives, architects, engineers, contractors, infection control, and others who address issues of healthcare acquired infections. In March 2020, with the onset of the pandemic, HAIO organized meetings to evaluate and propose surge solutions for the pandemic. This has resulted in a series of meetings on timely issues related to the pandemic, and this is now the 13th session. Next slide. 67 healthcare organizations, architects, engineers, contractors, and others have participated in these sessions. And we thank each of you for the countless hours that have been spent on making this a success. Next slide. Today we have a full agenda with 2 sessions and several speakers, so we want to get right into that. But before we start, I want to ask for a word of introduction from the founder of HAIO, Richard Barnett.
Thanks, Stan. Welcome, everyone. And Stan, to you and Teresa, thanks for all that you've been doing to push the cause forward. We have a mission to save some lives, and we're very excited about the panels today, as well as the Room of the Future that we'll be building at Newton Wellesley Hospital very shortly. So thank you. I hope this is a great session. I'm sure it will be.
Teresa, would you like to?
Yep. So just a reminder, we're going to have 2 sessions, the FGI Whitepaper, and then infection control, the MOB, and ambulatory surgery center. So today we're very lucky to have John Williams, who I worked with on the paper this summer. He's an AHJ with the Washington State Department of Health. Candace Barter, Paula Buick, and myself, we all worked on the white paper and were participants in HAIO. So we want to make sure you understand what the white paper is for. It's an FGI dealing with the pandemic and all emergency situations. Right now, we're in the comment period, so we thought this was a really relevant timing for you to understand what's involved and also the process for you to provide comments. So I wanted to give a shout out to everybody on HAIO. We had 8 people from this organization participate in the FGI white paper, and our work is well represented. On the right is a slide of some of our work we did very, very early on, and that is part of the white paper. So thank you, everybody on this call. Your work really matters, and it's being represented nationally. So I'm going to turn it over to John now, and John, just let me know when you want me to advance the slides.
Absolutely. Thanks, Teresa. Well, thanks, folks, for taking some time today to let me join you. It's a pretty impressive organization that you have here, and it really heartens me that this work is going on all over the country. As you heard, there's been a significant effort afoot at the FGI to create some guidance for facilities facing emergency conditions. And a few weeks ago, the FGI published a paper called Guidance for Designing Health and Residential Care Facilities that Respond and Adapt to Emergency Conditions. And if you think that title is long, the paper is long itself. It's 716 pages, which is great because it's chock full of information, useful tools, and things that we hope will advance the process. Also, this isn't just a white paper. Inside are some draft recommendations for creating a brand new guidelines document. And that document really kind of boils down some of the foundational ideas into proposed regulatory guidance. So next slide, please.
I just want to point out, it's very easy to navigate. If you go on the table of contents, you just click on it and it will automatically send you to where you're looking for. So you don't have to go through all 700 pages.
Yes, hyperlinks everywhere. But before we get into the discussion, we want to let you know that the views and opinions expressed by any of the presenters today are our own and may not represent the official position of the FGI, the Emergency Conditions Committee, or the Health Guidelines Revision Committee. So next slide. Topics to cover. Again, we just want to walk you through a high overview of the document to prepare you for what you might see when you get into it, in hopes that you will actually get into it and review it. So to start off, the photo at the left I took last April. And at that point in time, during the COVID response, Washington State was scrambling with a wide array of partners to stand up some additional capacity in the healthcare system in our state. That day, we were reviewing a Army surgical hospital that was assembled in a Seattle area convention center, and it was essentially happened overnight. And everybody in the room had a set of questions. Is this okay? What existing physical plant rules can we waive? What can we not do? What do we have to do? And is it safe enough? And as AHJs, we were struggling with this idea of what is our relative level of due diligence? And that's what the questions were for that first couple of days and first few weeks, nothing but questions. And in the following week, there were hundreds of answers. Almost everybody had an idea, an approach, and the questions started to shift to which answers do we listen to and which do we pay attention to? Next, please. So why the FGI? As hopefully you all know by now, the FGI takes a really deliberate approach to creating standards, and a very collaborative approach at that. Each of our documents is vetted by a multidisciplinary team. Most times in these teams, the designers don't agree with the clinicians, who don't agree with the administrators, who don't agree with the HJs. And it's that push and pull of opinions and viewpoints that ultimately crafts a really great document. We make every effort to base these documents on solid evidence. When we don't have evidence, we're going to rely on the viewpoints of the committee, debate, and just that wealth of experience around the table. And what hopefully that does is it weeds out proposals that unduly focus on special interests or those that go beyond the minimum. All the while, we're writing in language that can be easily adopted and enforced by state and federal agencies. At the end of the day, I hope this creates a well-rounded and well-founded document. So when the world was getting a little chaotic last spring, a lot of folks, a lot of organizations started reaching out to the FGI for guidance on how to deal with these facilities. And while we didn't want to add to the noise that was circulating around, we felt that we had a responsibility to do what we do best, and that's convene the experts, listen to that wide range of viewpoints, brainstorm with a lens, and create some baseline standards for facilities. So that's effectively what happened. Next slide, please. So we've got a pretty robust committee of 130 subject matter experts that work in some aspect of healthcare, from design to ventilation to code enforcement to infection control. And that includes many people on this call. And we are indebted to you for that experience and that time that you brought to this. These experts were subdivided into the 9 subcommittees that were shown on the right side of the document. These were the individual lenses that we used to view the disaster through. Next slide. One concept emerged pretty early on, and that was the need to view the disaster in a series of phases. So this is a chart from FEMA's National Disaster Recovery Framework and illustrates this concept pretty well. So if starting on the left side, before the event, we're in the planning stage, and the tools that we're using are things like the FGI, the building code, the life safety code to design buildings as per normal. And then there's the event, whatever the event is, if it's a short-term, long-term, rising tide, sudden surge, whatever. Immediately after the event, there is this short-term, immediate time frame where the efforts, everybody's efforts focus around triage, treatment, and sustaining life. And that short-term, immediate, temporary time frame extends, and it continues up to about 60 days after an emergency. And during that time, we're providing medically necessary treatment in temporary locations that probably don't meet the building code, but we expect them to meet some basic life, health, and sanitation needs. Then the next is the intermediate time frame, where, intermediate time frame where we're going back that spans about 180 days. And this is the bridge solution where whatever structures we're looking at should meet the most basic code requirement. And then we get into long-term solutions, and those have to be constructed to full code compliance. Next slide. Now we're going to look at the chapters. I think of these chapters as really a particular vantage point on disaster preparedness. We asked each subcommittee to develop some narrative ideas independently, and then we asked them to create recommendations that they thought might be actual regulatory text. And while each of these vantage points may see the same things, may have blind spots, hopefully together we think we're looking at it from a range of vantage points, and we get a good overall picture. And to that point, we consolidated all of the recommended mandatory language at the end of the chapter, at the end of the white paper. We eliminated duplicates and removed any conflicts. So the regulatory language that you see in the white paper at the end of the appendix is that perspective that's combined of all of these different committees. And based on the time that we were doing it, it's also based on the 2018 version of the guidelines. So chapter 1 is risk assessments. We're familiar with safety risk assessments. We've been using them. The safety risk assessment has been in the FGI for 3 cycles, and we use it to guide a lot of our decisions. This white paper expands that to include a new disaster emergency vulnerability assessment, or the DEVA. And the DEVA is something that comes alongside the hazard vulnerability assessment, or HVA, that is a CMS requirement. Any recommendations are specific to the particular location, type of facility, and so on, because we have such a wide range of facilities and locations across the country. Next chapter is on surge capacity, and this chapter tries to imagine what you can do inside of your existing building or existing campus to accommodate surge. And Candace, you were on this group. Do you want to share your takeaways?
Sure, John, thank you. Thanks for having me today. This was a really exciting process to be a part of. This was my first opportunity to work with FGI, and I think it was made easier by the participation in HAIO and the information that we were able to bring forward from this group. So we started the process with information gathering, really putting in a folder all of the information to date that the folks that were on my subcommittee had gathered and produced, and we included all of the work that was done by the HAIO Surge Solutions Task Force. And I felt pretty proud of being part of this group, because I don't think there was any other groups that contributed so robustly to this. I know that this was,
I think they all feel that way.
This was work that was done, I think, across many different subcommittees. So then our particular subcommittee, we did have representation. Teresa was in a leadership position on our subcommittee, as well as from across almost all of our subcommittees had HAIO representation on it. We broke it down based on the guidelines. And so we had these different committees that we were looking at: patient care units, diagnostic and treatment areas, patient support facilities, and general support facilities. And we kind of dug into that, focusing on these areas that you see in the colored squares, really making sure that we were taking the time to think about the guidelines. Obviously, they were written during a time when we couldn't foresee that we would be in a pandemic, but we also wanted to look at other ways that health systems can surge, like a nor'easter, which we're very familiar with in the Northeast. But we also talked to some area hospitals about the surge that happened after the Boston Marathon bombing. So we tried to make sure that we were taking some time to look at various instances that could cause a surge, and looking at the guidelines to understand what are things that maybe we should have recommendations around if there is a surge, and what are things that could be modified in the base guidelines to understand how we could make sure that facilities were more better prepared in the future.
Excellent, thank you. The alternate care site chapter is the next chapter, and it talks about what looks at the issue if you can't surge inside of your existing building. And what this chapter in the committee did is evaluated alternatives to stick-built construction, things like tents, arenas, hotels, repurposing existing facilities for different uses. And this subcommittee really focused on some fundamental questions like what care needs to be provided, how can you best provide that care, and what can we get done in the time and the resources available. So their recommendations are really based around length of time and service and the levels of infrastructure support that's provided. And this group really created a neat downloadable compliance matrix that can be completed in anticipation of events. So you can go download that and get some really good advice. This group also worked on modular recommendations. So there was a modular subcommittee, modular unit subcommittee, and most modular units can be designed to meet all, if not most, requirements in the guidelines. Unfortunately, from my experience, I saw a lot of mobile providers marketing their products as fully code compliant. And while that might have been true for a business occupancy, they were clearly not healthcare occupancies and didn't have the infrastructure support inside of them. So this subcommittee recommends working with your AHJs to plan a modular unit that can be pre-approved for healthcare use. This is an interesting concept, but it would really allow a quick scale up of production and quick deployment when we need those. So next slide. Chapter 4 is resiliency, and the white paper defines resiliency as a health or residential care facility's ability to withstand adverse effects. And this chapter is really suggesting ways a facility should plan and prepare and be able to absorb that surge event and then recover and adapt. So this group has a couple of interesting recommendations as new requirements. One is an incident command center with some specific guidelines around size. And the next is the idea that you need to site all of your critical support areas above the floodplain. And we've talked about that in the building codes when we talk about generator location and things like that. But this is talking about services like pharmacy, lab, those things that are intrinsic to the healthcare organization. Chapter 5 considered projects, renovations, and brand new facilities, and really asked how best to equip facilities for making decisions about what should go into those projects. And I think of this as, you know, the how far do we go chapter. And Paula, you were on this committee. Do you want to share your impressions, please?
And this is Stan Hunter. I was just asked to interject with a 10-minute warning. So thank you.
Thank you, Stan.
Too much out there.
And thank you,
all
Don.
right.
In the interest of time, I'm just going to highlight 4 things on this key elements for our group. The first was rethinking the hospital planning. And I think we heard from some of you, some of the ideas that you went back to look at, and we heard from around the country. So some of our planning in recent times has been an institute model where we've had outpatients, inpatients, imaging, and different types all commingled in a building. And some systems around the country have gone and looked at that model to see, is that a model that's going to hold up? I know that Steve Carberry and his team probably looked a lot at that. The other thing is this chapter is very overlapping. We tried to make sure it didn't overlap with surge and the operations groups. The third thing that we really are looking at is investing in caregiver needs and caregiver support staff. I think this has highlighted that it's not enough to give the staff break room a window and say you've done all you can for the staff. We have to go more, and we've got some good recommendations on that. And the other thing in that chapter is the case studies and interviews. And some of those are official in the document, but you're going to see your contribution really throughout in fact, our section and the other chapters where your contributions were made. This is just showing you how did we organize this chapter. We looked at it from 3 levels: the basic response, an enhanced response, and an advanced. And the advanced response are for those facilities who really can afford either the space or the finances to provide more space. And so this is a was a good way to organize the recommendations in those categories so that you could see where you fall into them. So how did we arrive at them? You can imagine how many recommendations there were, but certainly timing, surge, we talked about the big bang or the rising tide to really try and cover everything, and duration were the key elements. And the final slide here for us, really, again, the highlights are the AII rooms, the airborne isolation rooms, the numbers of them, the type, the distribution of them was a big conversation. I don't think any of us have used the words donning and doffing as so many times in 2019, but we certainly learned a lot of 2020, but we certainly learned a lot about it. The intensive care units were another critical element. I'd highly recommend you go to the Society for Critical Care Medicine for their white paper on design of the intensive care unit, nurse stations outside the rooms, things like that. There are 16 institutions across the country that contributed to that. Lots of really practical ideas that we used in our literature review. And I think that's okay.
Sorry, Paul.
That's all right. I think that's fine. We have to move on.
Thanks, Paula. Chapter 6 looks at the problem from the perspective of a wide range of different smaller and rural facilities. And while these, the chapter really focuses not just on rural, but smaller facilities everywhere in suburban and even urban areas, they identified a common set of challenges like remoteness, access to capital, and community support. And this subcommittee took the approach of developing what they call a disruptor matrix that looked at particular things that challenged these types of facilities and really illuminated their particular vulnerabilities. And that disruptor matrix helped plot out a set of responses tailored to address the specific weaknesses. Chapter 7 is emergency preparedness in residential care facilities, and this subcommittee really tackled a wide range, a really, really broad topic of a wide range of different facilities, and chose to focus down just on nursing homes, hospice, and assisted living facilities. And these are the ones, the facility types where residents are more reliant on the caregivers and therefore at greater risk. They came up with one of the more controversial recommendations in our proposed regulatory language, and that's to provide single occupant resident rooms in all of these residential care facilities. And then another requirement is for a visitation room. As many of you know, getting in to see your loved ones inside of these facilities were a challenge. Big challenge over the past year. So we're interested to see where those recommendations go. Operational considerations. The guidelines have really kind of shied away from getting into operational issues and matters. However, we thought it was important to have that perspective as another lens to view this effort through. So many of the allowances and alternative methods described here assumed that there's an operational overlay that's going to bridge some of those holes and cover some of those risks. So the Operational Considerations Committee made a lot of recommendations specific to each chapter, and they basically came behind each chapter and gave an overall view of how those chapters impact operations and approached it from that perspective. So you won't see an individual chapter, but just know their work is dispersed throughout all of the chapters. So at the end of the day, after all of those chapters, you have an appendix with a lot of really fascinating case studies with interesting ideas and concepts and approaches. You have a set of regulatory recommendations at the end of every chapter, and then a big sort of consolidated set of recommendations at the end of the white paper. There are all sorts of tools, proposed matrices, downloadable Excel spreadsheets. It's really, really full of some great ideas. And after all of that brainstorming and consolidation, you've got a white paper that's a narrative. And when you open it up, it will look hopefully familiar to you. It's using regulatory language, and the regulatory portions of it have additions to the existing guidelines, as underlines and any redactions struck through. So logistics wise, the white paper and the associated guideline was released on April 1st. It's available for free download on the FGI's website. And we would encourage you to download it and the alternate care sites compliance matrix that's in the same location and share them widely with everyone that you think might be interested in that. The public comment period has already begun and it's going to remain open until the end of June. We're hoping to get a lot of feedback through the comment site. This is the first time this idea has been broadly dispersed among the public. So we're hoping we're getting a lot of feedback, and we'll look at going back and editing the white paper, but really kind of structuring this thing that we think might be a good regulatory document in short order. Here's the website where you can make comment, and that's the emergencyconditions.fgiguidelines.net that shows up on the bottom of the slide there. The site may be familiar to you. It's essentially the same one that we've used to comment on the FGI guidelines for the past couple of years. So if you submitted a proposal in the 2022 FGI cycle, your username and password should still work. Next slide. The comment system is pretty intuitive. You just navigate to the section that you want to question or change, you add your language, and then you add your reason statement. Originally, we were thinking about a lot of different ways to roll this out. Was this going to be new standards in the 2022 version? Is it going to be a freestanding guideline? We intend to publish this as a new standard. Just because it's published doesn't make it a rule. It's going to be available for adoption by state and federal agencies or private accreditation organizations. Several people were really interested in putting it into the 2022 edition of the FGI, but the leadership decided it's more important to give these ideas a chance to mature before we fold them into actual regulatory documents. But we do anticipate that this will be part of the conversation as we move forward into the 2026 version of the hospital outpatient and residential guidelines. And so in conclusion, next steps, please review the draft guidelines, be aware of the 3-month comment period. The Emergency Conditions Committee Steering Committee is going to review and all of the votes and comments that were received. Any accepted comments are going to be incorporated into this new edition of the ECC guidelines, and then we'll publish that as a supplemental. So I think we got a minute for questions.
You did. Thank you so
That's
much
incredible.
for that marathon review. That was awesome. And I really want to, again, thank everybody in HAIO who worked throughout all of these sessions, because all that information was in our heads, and we shared it with people from around the country, and a lot of it is within these documents. And also, as a reminder, these links, I believe, are included in the invitation to this meeting, so you can access them there also.
Great. Thank you very much, Teresa. Incredible. Having witnessed Teresa's effort and commitment on this project, it was an incredible undertaking, and extend my thank you for the incredible work on that. Can you go to the next slide, Teresa?
I think Matt's going to share his screen now.
Okay, Matt, if you could pull up the next slide. I can share screen.
Okay.
Okay. Great. So if you can see hopefully everybody can see my slide. We can get a confirmation, and if the speakers for this next session could come on screen, that would be great. Okay, super. Now I can see what's going on. So last meeting, number 12, we had a roundtable with healthcare leaders, and one recurring theme of that was the continued and possibly accelerated development of off-site outpatient facilities, such as MOBs and ambulatory surgery centers. This being the Healthcare Acquired Infections Organization, we wanted to follow up on that discussion that was brought up last month in several sessions, and and dive into that further from the perspective of infection control and prevention at those types of facilities. And for that, we've developed a very diverse and panel with various backgrounds and approaches to infection prevention. If people that are not on the panel could go off a video, that would be appreciated very much. And thank you. With that, we have myself doing the introduction, Richard Weiner, Ellen Vope, Preeti Mayotra, Sonia Rivera-Sands, Madeline Bartz, and Steve Carberry doing final remarks. And we're going to go in that order. So next slide is here. Great. And we've asked 4 general questions of the panel, and I'm not asking each panel member to answer all 4, but to focus on their more area of their expertise as they go about this. And each will talk for 3 to 5 minutes on their perspective of this question of addressing infection control at ambulatory surgery and medical office building settings. So first, Dr. Weiner, if you could. Yeah.
All right, good morning. Thanks for the opportunity to be on this panel. This organization is extremely impressive in all the work that you've done, especially considering that it's all volunteer. So again, hats off to you and thank you for all the hard work. Before I was a hospital president, I was actually a surgeon, a vascular and general surgeon. I'm now a recovering surgeon, and this is my ending my 4th year as hospital president. So I bring that perspective to this role, which has been helpful during this pandemic. As far as the first question is concerned, we transferred blocks from the main OR over to our ASC. We have a 4-room ASC about 3 blocks away. We did that originally because we wanted to decompress the main OR in preparation for a renovation. But turned out during a pandemic, that was very helpful. Patients, for some reason, didn't want to come to a hospital during a pandemic. I can't imagine why. And they much preferred going to an ASC. So when we were allowed to do elective surgery, we were able to do it at the ASC. And as I said, it did free up capacity in the main OR for more complicated and equipment intense procedures. For the second question, we practice social distancing, but it's pretty much throughout the facility, the ASC. The waiting room, there's a cafe there, which is also used by our cancer center next door. Visitor restriction, that was different. The whole requirement of pre-op COVID testing added a little bit of complexity. So the ASC is not like the hospital operating 24/7. So there's not always staff on site nights and weekends, which makes temperature and humidity monitoring even more important to be done effectively. We have to transport sterile supplies back and forth from the hospital and the ASC, and also dirty instruments. The infection prevention folks partner and collaborate with CMS and the ASC management to make sure that our policies and procedures are followed. For the third question, who is responsible? The Winchester Hospital Infection Prevention Team is responsible. They visit and evaluate actually a minimum annually. It's never that infrequent, and it's also on an as-needed basis. Wonderful individuals that are a tremendous resource and very well respected. We had to remove furniture from the waiting areas and assessment rooms, break rooms, and that helped maintain social distancing. We also had COVID testing order built into our Epic physician order sheet, and that helped with compliance. Last question, are there any lessons learned? Yeah, pandemics are something you should avoid at all costs. But if you can't, you absolutely have to have rock solid infection control guidelines implemented at all of your sites, not just the main hospital. Anesthesia department had, of course, used evidence-based guidelines for any new products they would bring in, but it really was a team sport. And I would say the lessons learned, we do not have any negative pressure rooms in our pre-op and post-op rooms. We do have them at the hospital, but that's consideration for the next one. I think the rest pretty much said earlier. So that's what I have. Thank you for the opportunity.
Thank you very much. And I'm actually going to go off of sharing my screen so that we can see the speakers on your computer, unless anybody has an issue with my taking away the questions. There you go. Super. And the next speaker is Ellen Vope from Vice President of Ambulatory Surgeries at Beth Israel Deaconess Medical Center, and will speak to this with some of the operational perspective as well.
Right. Good morning.
Ellen,
Thanks for having me. Yes, I do represent sort of the operational perspective. And when I looked at these questions, we have at Beth Israel Deaconess Medical Center, we have 6 offsite locations. They're all very different from each other. But through this entire process over the past, 14 months or wherever we are now, I think what made this a unique experience was that the infection control practitioners in our hospital work collaboratively with the operations folks and the facilities folks and cover the on-site as well as the off-site equally. So there's no difference in what happens at the off-sites. They're all treated as if they were following all of the same rules. And I think that one of the, Dr. Weiner already said something about the team approach, but that truly, like when I tell you I spent more hours with the facilities guy and the infection control guy than my entire family for months on end, I'm not kidding. And we kept going back, and we have 109 clinics. We went to every single one over and over again, every time there was a change to see what was, I think there's, you put out these rules and you go on talks and you tell people what to do, but unless you actually physically go there and say, no, this isn't exactly what we meant, and this is what it means. I moved the furniture myself. It was really hands-on and in the field for sure as a group, because each of the 3 of us have a very different perspective. And we were able to be successful, I think, in getting the message out and making all of the locations safe for our patients during this process. I think that we do visit on a frequent basis, mostly for Joint Commission prep. The 3 of us had already had a solid working relationship before the pandemic, so it was very easy to sort of just pick up and move out to do whatever it was we needed to do. And also the 3 of us, because it was a consistent group of people, it wasn't like, oh, well, a different team understood the rules differently. So there was significant consistency about it. We also, to Dr. Weiner's point, also, it was fascinating to me when we did, I guess it was last May when we sort of implemented a recovery program. The patients did not want to come to Boston. Our clinics in the offsite places were like chock full of patients, even though I'm like, okay, we're doing the same thing, but definitely the patient perception was it's safer in Chestnut Hill than it is in Brookline, which doesn't actually make sense out loud, but that is definitely what the perception was. So in hindsight, I'm glad that we spent as much time at the offsites and didn't treat them like the second class group to look at, because that's where the patients went first when they returned. So I think our strategy was effective. I'll end there because I know that my partner, Dr. Mayotra, has all the infection control clinical part for it.
Yeah, and we are very pleased to have 3 infection control experts on the call, and we'll have each of them speak now on their perspective, both from the pandemic, but also going forward from here as operating existing facilities and new facilities are introduced over time. Dr. Mayotra.
Thanks for having me, everyone. So I am lucky to be the Senior Medical Director of Infection Control at the Beth Israel Deaconess Medical Center. So I work very closely with Ellen Vope and, of course, our facilities colleagues, as she mentioned. But in addition to that, I'm also a Medical Director of Infection Control at Atrius Health, and I'm pleased to be joined by my colleague, Sonia Rivera-Saenz, who's Director of the Infection Preventionists at Atrius Health. So in my capacity, I'm extraordinarily lucky because I get to see the whole spectrum. I get to see and operate primarily based in the inpatient setting with our outpatient locations, both on campus within the inpatient facility, but also at offsite locations, as Ellen mentioned, in my BADMC capacity, in my Atrius Health capacity. It's a very different role, which Sonia will speak to, which is a set of 32 very diverse by physical plant standards locations all across Massachusetts. And so that is the spectrum that exists out there of ambulatory infection control. What I would say is that even pre-pandemic, there has definitely been a shift towards moving procedures into the ambulatory setting. And that includes not just minor surgical procedures, but also what might have been traditionally considered same day or 24-hour admit operations into the ambulatory setting. And that has very real impact from the infection prevention control setting, not just from the standpoint of how we approach the building and design of locations where there need to be procedures or surgeries done, but also has real financial impact because that changes the way that hospitals will need to approach their surveillance. If there are more procedures that are done in the outpatient setting, that means by proxy, less procedures are done in the inpatient setting, which has impact from the standpoint of dollars and finances. So that sort of trend was there, I'd say, even pre-pandemic, and I think is continuing that way even post-pandemic as we try to think about traffic flow and congestion and what actually comes into inpatient settings. I think one thing that this is certainly highlighted for me is that there is a complete heterogeneity of physical plant in the ambulatory setting. We have everything from kind of the kind of mom and pop house that might have been converted into a medical office building to more refined ambulatory surgical centers that look for all the world like they might be in an inpatient setting. And so getting a grip on that heterogeneity, I think, is something that everybody in infection control and prevention needs to wrap their brain around. And we also, I think, I don't want to speak for everybody on the call, but I'm always certainly surprised at the creative ways in which what once might have been a closet has been turned into a space where we do high-level disinfection, for example. So thinking about clean and dirty workflow, the use of equipment and I'd say, equipment itself within the room and also high-level disinfection work are certainly top of mind when we think about the future of medical office buildings and potential ambulatory surgical centers. And then I'd say the infection prevention workforce is a real issue. I think that traditionally much of the regulatory efforts have focused on the inpatient setting, and to my mind, the future is ambulatory, especially as procedures continue to shunt in that direction and more medical care continues to shunt in that direction. And so really thinking about how we staff our infection and prevention workforce to be able to adequately more than once a year, which is, I think, is the minimum, that our infection preventionists go out to our offsite locations. How we make that more robust and more part of our standing work is certainly something that I think the future portends. But I'm sure both of my infection prevention and control colleagues on the call will have a lot more to say about that. Thanks so much for having me again.
Thank you very much. And Sonia Sands from Atrius, join us, that'd be great.
Hello?
Yes, there we go.
Thank you very much. Sorry, I had a connection issue for a second. So I'd just like to thank you all for the opportunity today. My name is Sonia Rivera-Saenz, and I'm the director of the Infection Control Program at Atrius Health. And I would like to chime in and kind of elaborate on some of Preeti's remarks as well. So in terms of our staffing and our workforce, we're under the great clinical leadership of Dr. Mayotra. And in terms of infection preventionists, there's myself and 2 other colleagues for Atrius Health. So we're unique in that we're purely ambulatory care, so not attached to a hospital setting, but 32 outpatient sites in the greater Boston area. In terms of some of the challenges, particularly for infection control at our facilities, I think of it as almost some that are impacted by the pandemic and others that were constant, before, during, and after the pandemic. So as Preeti touched upon, clean and dirty spaces can be a real challenge. So in terms of instrument reprocessing, we have over 100 autoclaves across Atrius Health, so across our sites, to really think about the autonomy, where those are located in departments. We sterilize instruments across all of our sites. And in addition to that, we have different departments with high-level disinfection, including ENT, urology, and endoscopy departments. So there, when you have such a variety of sites, let's say some of our well-established DPH licensed sites, and then other sites that are not DPH licensed, are more of those mom and pop type office-based settings, then you really encounter different challenges there and differences and ways staff can appropriately and safely high-level disinfect instruments. So this has required sometimes advocating for the development and construction of a utility room, or auditing the site, seeing how you can support that site, and being able to safely reprocess instruments and perform high-level disinfection there. So wide spectrum in terms of variety of our sites overall. And then in terms of impacts of the pandemic and concerns, I think when you got into stopping non-urgent procedures and then resuming them, some of the re-education that required as well during that pandemic, during the reopening of healthcare facilities, that was a particular challenge to make sure that everyone was re-educated on the process. If there was new staff, that they were up to date on those processes as well. Was something that was definitely a lessons learned there. So really clean and dirty work spaces, sometimes not having that clear differentiation between a clean and dirty utility room and ambulatory care. It's a challenge in creating safe, dirty to clean workflows. It's a common theme in terms of ambulatory care. In terms of our staffing, we divide and conquer it. So there's 3 of us as infection preventionists. We go to our sites at least 2 times annually, I'd say, for the 32 sites, at least once every 6 months, and more often as requested. So some sites may need more frequent visits by each of us, so it can be more often, but we try to go at least 2 times a year in terms of in-person. And in terms of lessons learned, I think standardizing across outpatient sites and infection control has been the biggest challenge. So making sure everyone can operate in the same way. And what that means in terms of guidance developed by our infection control team is really thinking about, how are you screening a patient that's suspect for COVID? How do you immediately isolate them, have them escorted to an exam room in sites that are very different? Some where it's very easy and they're all one floor, others where they're very robust multi-floor entities, and making sure that staff in different sites are able to do that effectively. Also donning and doffing of PPE, making sure there's actually different discrepancies there, or sometimes that requires a visit to really work with that staff and make sure that can be standardized in a safe way. So those are common challenges in terms of the way our sites are laid out. Thank you.
Thank you so much. And it's just as an observation, there's interesting overlap of the different themes from the different organizations. And I'm Madeline, who's speaking next, to help me sort out some of the questions that would be asked and some of the preparation for this. And I appreciate her work on that. And it's interesting to see the different differences and similarities in what's being talked about. One thing we talked about a fair amount as we were planning this, should we have a whole piece on the cleaning of instruments and central sterile processing. We kind of decided that could be an entire session itself. But it's great to hear that mentioned in several of these discussions. But Madeline, if you that would be great if you could speak also from your perspective as at Newton Wellesley Hospital.
Sure. Hi, thank you so much for having me. So I'm Madeline Bartz, a registered nurse, and I am the infection preventionist at Newton Wellesley Hospital. Obviously it has been a very challenging year for all of us, but it's also been a great opportunity to look at things in a new way. Something that, in preparing for this discussion that we really focused on and it is critically important is, the difference between the physical infrastructure and the visible infrastructure, and then the invisible infrastructure. So, and I think Sonia touched on this a little bit, is that there are very different physical spaces in our ambulatory sites. So there's some are licensed under our hospital, and we have, very tight and organized processes for going there, reviewing the processes. And then there are some in our medical office buildings, which are physically attached to our hospital. And I'm not sure if this is, unique to us or more common, where there are affiliated practices. So they're, they feed patients into Newton Wellesley Hospital, but they, are separate from us. And the lines for, what they follow and adopt from us and what they don't have to, if they don't want to, it can be blurry at times. And that's really been a challenge through COVID-19 when we think about contact tracing and working with them if there's been an employee that's had COVID and we want to contact trace their colleagues. There are certain ones that have welcomed us, and then there have been other ones where they have chosen not to work with us and have worked with the local and state public health authorities instead. Depending, we try to be very strict and cautious when it comes to making sure that we're not spreading COVID-19 in the hospital setting or in our ambulatory sites. But that heterogeneity has been a challenge for us through COVID-19. Back to the invisible infrastructure that's so critically important is the electronic medical record. And if you have a number of ambulatory sites, making sure that there is a uniform medical record for whatever you are looking at has proven to be really important through COVID-19 because of the visibility of test results. If someone's tested positive, there's a lot more complex interpretation of COVID results than just positive or negative. When we think about vaccination and people who have recovered from COVID and might persistently test positive, people who are immunocompromised and need, their results interpreted with more expertise than might necessarily be found. So being able for infection control to be a resource to the ambulatory sites to help in those kind of special situations is really important, and making sure that all the information is available to the infection preventionists as well as to the front desk staff. So if that person's had a recent positive COVID result, but they've been waiting for the special appointment for 6 months, not every patient is going to cancel that long awaited appointment. They want to go see their provider. They've been waiting a long time for this. So, they might try to skate through the system and arrive after they've, only quarantined for a few days after their COVID-19 diagnosis. So, trying to make sure that the person that first sees that patient is aware of their COVID status, and, thinking about preparedness in future pandemics, is there kind of a way to triage patients or to understand who might be at risk, and thinking about travel screening as we think about Ebola preparedness and other important aspects to try and prevent this from happening again and from preventing infection in the ambulatory sites, the MOBs, and the inpatient setting. I would also just, think about as we go forward, and, I think everyone agrees that care is really moving out to the ambulatory sites and further into the community, which I think is a wonderful thing for public health, but also, when patients do require a higher level of care, that whatever medical record is being used by their outpatient provider is available and easily visible to the hospital that they'll be going to. Whenever that happens, there is a safer transition for the patient so that all the information is readily available for that next caregiver. So, there's that, I think, would be one of the biggest takeaways for us at Newton Wellesley Hospital is the importance of, the medical record and being able to keep track of patients and their status that way. And then I echo Sonia, it was really great to hear about the clean to dirty workflow in Atrius and some of the heterogeneity in the physical space. And I think those are also, possible challenges that are faced in ambulatory sites who might be one-off, but who feed patients towards us. And we want to make sure that if they're on our physical location, that all the right things for infection control are happening for the patient.
Great.
Thank you.
Thank you. And finally, I have called on Steve Carberry to give final remarks and thoughts on this talk. Steve has been a great contributor to many of the calls, and I give him the two-minute drill of synthesizing some of the thoughts and bringing it back to the facilities perspective. Steve.
Well, good night, everybody. Good to see you. 2 minutes. Okay. We've got 3 minutes left. All right. I think what we've heard today, and this is no different than what we've talked about in the past, this has been a team sport between facilities, infection prevention, and our offsite folks, looking at the physical infrastructure. How do we manage the shift from inpatient to outpatient, during the pandemic? Outpatient facilities absolutely were felt to be safe. Inpatient, not so safe. That's where the COVID patients were. So we really had to shift a lot of clinics to the offsite locations, make sure that they were, kept clean, and make sure people saw them being cleaned, I think was a big piece of what made people feel ambulatory was safe. I think we saw that our infrastructure in certainly the medium box and big box locations worked as designed and worked well. We didn't have the flexibility to modify them as maybe some of the other locations, but they did the job. And I think that speaks well for the investment that we've put in there. That there were an awful lot of folks trying to sell us stuff during this pandemic, and we had to be very careful about ionization systems and UV systems going in, which may or may not have been proven. So we had to be careful with that. Madeline was a great intro into IT and video conferencing, video visits, pre-registration. Really was an uptick in this, and I think helped really control the social distancing, allowing us to spread out appointments. You've heard of all the modifications to the waiting room, plexiglass everywhere, that we could separate everything off. I wish I had stock in DuPont prior to this. So it really, it proved the value of the investments that we've made in locations. I think we'll continue to relook at how we design spaces in the future. Self-rooming will become more and more important as we go forward. And, what are we going to do with all those waiting rooms? So we could go on and on and on. And I think as Dr. Malhotra said, if you've seen one location, you've seen one location. We do have an awful lot of variation in our offsites, from houses to 100,000 square foot ambulatory surgery centers with pretty sophisticated systems. So it does run the gamut. And I think that's continuing to be a challenge for us.
Great. Thank you. Thank you so much. We're at the hour. This is a great discussion. Really appreciate it. And thank each of the panelists for your thoughts on this. Richard, any final comments that you'd like to add? We videotape this, so this will be available, and we will start working on the next session that we will have in approximately six to eight weeks down the road. Richard?
Thank you, Stan. Just a big thank you to all of those that participated in this. We are making a difference, and we will continue to do the same. Thank you.
Great. Thank you very much, everybody. Have a good day.